So, welcome everybody. It's a big pleasure to be with you all. And I have a panel which is highly informed and you'll get a lot of considered views. In terms of introduction, most of the people on the panel do not need an introduction, but I will tell you how well they form a 360-degree team for this discussion. So we have a very big public provider and regulator, that is Dr. Rajiv Garg from DGHS. So as you know, all the central government hospitals come under DGHS and CDSCO also comes under DGHS. Then we have a very big private provider association represented by Dr. Girdhar Gyani, who is the Secretary General of Association of Healthcare Providers of India. Then we have a manufacturing ecosystem provider in Dr. Jitendar Sharma, who is the Managing Director of Andhra Pradesh MedTech Zone and also advisor to Niti Aayog. Then we have an importer and an educator in Rajiv Nandan, who represents Alcon, the largest company in IOLs. Then we have Anish, who represents a very big company in the manufacturing space. Also, he brings the investor's lens in. And we also have Jaishankar Natrajan, who is not only a manufacturer, he's also a technology evangelist. So this is the panel we have, and I would like to straight away come to the discussion. So, and let me begin with Dr. Girdhar Gyani. Dr. Saab, given COVID, how do you think the dialogue on healthcare has changed? And what are the main challenges you see which healthcare faces in the country today?
Okay, Namaskar, Pawan Chaudhary and my colleagues on the panel. COVID has only brought us the attention on the healthcare in very serious terms. I was telling that the word disruption, which we have been using for past 5 years, more for a fashion sake, more for a seminar sake. But this COVID has actually brought the disruption in the true sense. We have actually realized which are the gaps in our healthcare systems. Now, otherwise, COVID cannot help us to overcome these gaps in just 6 months. Although I will say a little bit about that also, what we have been able to do in 6 months. But to just start with, let me start with a survey done by WHO, where India has been ranked as 145 out of 195 nations on the effectiveness of the health system. So that is the 145 out of 195 countries. Now, why it is so? This is largely because they evaluate us on the 4 factors of the universal health coverage. That is known as availability, accessibility, affordability, and acceptability in terms of quality and safety. Now, briefly on availability, our problem is that we should have 1.3 thousand population as per the WHO norm for developing countries. Presently 1.3 beds per 1,000 population. So that means roughly we have 16 lakhs of the beds in the country. Ideally, we need 40 lakhs. So that means 2.5 times actually we have to go. So that is a big gap existing there. Out of 60 lakhs, it is roughly 50% you can say. Exact data is not available from the private sector, although the government sector data is available. So, but roughly 8 lakhs beds are available. The problem here is that the private sector provides you 85% of the tertiary care beds. So that means for tertiary care, the nation is dependent heavily on the private sector. That is why you see, most of the VIPs, when they fall sick in terms of COVID or otherwise also, they have to actually go to the private sector, not because the government sector is poor, but because they have limited capacity in terms of tertiary care. So that is one. Second, now comes to the accessibility. Now, why we have been rated poor? In fact, earlier survey we were only 112 out of 191. And that one they elaborated with the data that in India, most of the secondary and tertiary care hospitals are confined to tier 1 and tier 2 cities. They found very little hospitals are available in tier 3. So they said that means your accessibility of India is very poor. Coming to the doctors, I think this is a very well known ratio that we have 0.7 doctors per 1,000. What we need is 1 doctor per 1,000. Major problem, which actually is not highlighted in the survey, is that it is not MBBS doctors. Actually, we need specialists. Today, even if you are having 18 years of experience in MBBS and you have been practicing, let us say, anesthesia, can't inject anesthesia on the patient. If something goes wrong, legally you will be held accountable. So actually, it is a shortage of the specialist. And that is where the current situation luckily has improved drastically. We have 80,000 MBBS seats and 50,000 have become the postgraduate. So I think reasonable progress has been made in past years. So this is where actually I'm saying that infrastructure wise, we have still a lot to do in terms of availability and more importantly, improving the accessibility by distributing the hospital across in 3 cities. So I think begin with, this is the data which I can share. I will join a little later once, there is a question where the discussion, one more point, of course, the as you know, is 1.2% of GDP. Private sector is spending 3.8% of GDP. One way it is a smart move which nobody talks open, that governments will like to, private sector to invest and they keep their own money for some other sector. So it is in a way, it is a smart move provided you regulate the private industry intelligently. Now that is, I think we will discuss later along with Dr. Rajiv Garg and my colleague even Jitendar Sharma can pitch in later on the regulation. So you need any or is it okay with to start?
No, I think that was a good start, where we have highlighted the infrastructural deficiency, the manpower deficiency. What else would you like to add to this, Dr. Garg? What is it? What is your view regarding the market right now? We have begun talking about the market. Dr. Garg, Dr. Rajiv Garg. I think we have lost him. Dr. Jitendar Sharma, would you like to come in here? What else or let me ask Anish to step in here, and I'll come to you in a moment, Dr. Sharma. Anish, what else is missing in the market other than the infrastructure and the personnel?
So I think, Dr. Gyani made a very valid point that from 112th number, we've actually now moved to the 145th number, right? And a country our size, one is, of course, the infrastructure, but also the development of local organizations that are able to support the local patient base becomes very, very important. So, to Dr. Gyani's point, there are about 80,000 MBBS seats that have gotten created now. But the question is, what will be required to fill in the gap of almost 1 million doctors and 1 million nurses out there? And the private and government spend, of course, the government spend has to go up. If you look at somebody like in the US, the government spend is almost 17%, and we are at 1.2%, right? So the gap is significant. Now, they cannot be a one-to-one comparison. But I'll sort of represent the industry's point of view, and more specifically the MedTech industry, because clearly if the country has to provide viable healthcare to its patient base, it needs to have a very robust MedTech industry and products that are able to work not only on the surgical intervention side, but also on the prevention side. And there have been a lot of steps. For example, the AMTS that becomes a great breeding ground for companies like us. But clearly, the starting point would be a separation from mixing up with the pharmaceutical industry, right? The pharmaceutical industry and the medtech industries are two very different industries. And they require a very different sort of a skill set. They require a good interspersion of metallurgy, chemical, pharmaceutical skills to grow and to prosper in the country. Now, there is a lot that needs to be done in order for the medtech industry to evolve as far as the country is concerned. Because like the way we are lacking in the hospital space, similarly, our domestic medtech space is very, very small. A per capita spend is $3 as opposed to a Brazil's $21. I'm not even comparing us to anybody like the US. And this business doesn't have any tailwinds. There are a large number of SKUs. There's a lot of obsolescence. There is a need for new technology to be brought in at different junctures. And the way I see the evolution of India is not only going to be filling the infrastructure gap, but clearly accepting technology as a way of treating a much larger base of patients and also managing the affordability element, both by government intervention as well as by bringing the cost down, which will happen with the growth of the local industry, and a huge amount of that would be a contribution from the MSME segment.
Very, very good points. So basically, what you're saying is that in terms of regulations, drugs are a chemical entity and medical devices are electromechanical entities. And they should have a separate regulatory system, because what is required is not the knowledge of chemistry, but mechanical engineering, electrical engineering, hardware, and software to regulate medical devices. This is one point. And the second point which you are making is affordability, to which I'll go to Dr. Rajiv Garg, who's just joined us again, is that we should also look at the affordability affordability problem through the prism of technological innovation, and that some technologies can come which can make things more affordable without the physical issue or physical products coming into play. Dr. Rajiv Garg, pleasure to have you with us again. We were talking about the manpower shortage, which Dr. Girdhar Gyani has already explained in detail. What else is ailing healthcare sector today, or what is the second most important challenge before healthcare after infrastructure and personnel shortage?
Good morning. You see, seen that it is basically the governmental and non-governmental organization both are contributing. At the moment, we have treated or treating almost 37 lakh people as of today all over the country, and all levels of hospitals are in the channel of delivery of secondary and tertiary healthcare. But then we have to look at the ground zero level, where the sub centers, and at the peripheral level where the surveillance and testing is going on. So as we have seen in the last 7-8 months, that there has been an upheaval in the medical sector in terms of the requirements which are in the form of health health care personnel, drugs, diagnostics, as well as the infrastructure. And as we have seen that whatever the national programs, some of them are doing very well, some are not doing too well. But this kind of scale we have achieved for the very first time, almost as a mission mode. And the variety has been stupendous. Say a simple anti-malarial medicine like hydroxychloroquine to a life-saving device like a ventilator. And these, as we knew, when the epidemic began, we had a few meetings in the directorate. We were searching and fishing for ventilators, and the usual, the big names, they were not there around, because the market had opened up in the countries, and the things were disappearing very fast. In fact, some of the shipments were taken back by those countries. So the mobilization and the planning led to the development of the infrastructure locally, so-called Make in India. And what we have obtained in the resources is what has resulted in the, we have a low case fatality ratio of only 1.7 or so compared to the international one, which is 3.3%. So what the question today is that the regulatory organizations, as you mentioned, the drugs, the drugs and cosmetic act, that is what the CDSCO is taking care of. And by definition, medication includes not only drugs, but implants, prosthesis, blood and blood products, vaccines, and which are given to patients. Even gases are included. So what the government has been trying at the highest level is to make it, a transparent and a quick process. And it has shown results this time, because there were, 24/7 officers were sitting and they were clearing up the files. And it was not really a paper work, mainly the e-files, because everything was on the portal. The Sugam portal is there for the CDSCO, on which every document can be uploaded, and the regulatory permissions also are given online. So this kind of expediting the process has occurred for the very first time, and this has shown the capacity building can be done at a very large scale. Similarly, the devices, there were no such regulatory methods we could do. So what we did was to have the, the demonstrations, whether it was a simple oximeter, a tiny oximeter, right up to, say, a ventilator, full-fledged ventilator. And we had the committees here, the specialists were looking at these devices. And now the urgency has now, subsided. But then we realized that we should have involved organization like the BIS, and these standards should be there, which were not existing earlier. In fact, what was done to scale up the operations was to divide the, in the qualifications into essential and desirable. Some of the, low cost device just meeting the essential requirements, and the optional, part was left because we needed those devices very fast. So therefore, the question comes whether we can make it a standardized kind of procurement, and that is what the intent is. So
Yeah. I think Dr. Garg has very well made his points. The medical device or healthcare space, healthcare dialogue has really reached the lingua franca. I think that there is an echo. Dr. Saab, can you put your microphone off? Dr. Garg, yeah. I think that's better. So they have really reached the lingua franca. My house help also knows that ventilator is not only the space above the door, but a machine which saves lives. And my mother, who's a student of literature and English literature and bedridden today, very deficient in commercial understanding, knows what is a supply chain. So she understands that. So really, healthcare has come to the forefront. And the other point which you said, that regulations are evolving, there is greater agility among bureaucrats. Surely I take your point. And the other point which I wanted to mention, and which has been alluded to by Dr. Gyani also, was the purchasing power. So, and to that we will come in a moment. But before that, let us go to Dr. Sharma. Dr. Sharma, regarding the technological ecosystem and regulatory ecosystem and demystification of the manufacturing ecosystem, what are your comments?
Thank you very much, and to all the esteemed panelists. A good question and a good panel. But let me present the glass half full instead of half empty, or at least try to do so. the shortages about doctors and some centers and all those beautiful shortages that we talk about, we are actually talking about years or more. Aren't we tired? How long would we say that the world's largest democracy and the world's second most populous nation has shortage of nurses or doctors? And if we have shortage, what will happen to Rwanda and Botswana and Nigeria and Timor-Leste? So somewhere, I think the Indian mentality and attitude of blaming everything else except ourselves has to leave us. If world's second most populous country has a shortage of doctors or nurses or even a cobbler or a barber, there is a problem with us. And talking about shortage is less important than solving the problem. And that is where technology comes in. Because every time before the telemedicine rules came up in 2020, due to every time telemedicine was pitched in as a legal way of consulting and prescribing and dispensing drug, it was challenged by the practitioners of science itself, right? So I think what has happened is it has taken a gross conflict, a health conflict, for us to accept that cribbing and blaming about problems is not the solution. Accepting a solution as it is and improving upon it is the way forward. And while improving upon it, better may not become enemy of the good. Now, I'll just give you an example, a very simple example to justify that point. As Mr. Rajiv, Dr. Rajiv Garg mentioned, our esteemed senior colleague, clinical medicine himself, when India needed the BIS standards for ventilator did not exist. So, ventilator standards and specifications were made by a procuring agency, which is not a standard setting agency, because a procuring agency can only say what is good for them, not what is good for the whole of the country. A hospital can still buy a ventilator which is different from what the procurement agency thinks is good for that agency's requirement. But BIS is for the country. And therefore, he is right that the BIS standard should have existed. And therefore, the leadership in the procurement agency started with the specs. Today, BIS has a standard and specification of ventilator, which does not match with the specifications that are being used by a procurement agency. But that's okay, because the procurement agency for better to become enemy of the good. It started with something good enough. It did a job for the country. It allowed a statutory body to fulfill its mandate by creating a standard, which perfected those specs and standards, and now the test methods and the specifications valid for the entire country, which is not the same as what the specifications procurement agency is using for ventilator. Both exist, and that is fine, because we have justified and exemplified how we all can come together as a team, start from scratch, do something good enough, and perfect it over a period of time. We have not allowed to better it become any of the good.
No.
Therefore, my only point at this moment is medical device manufacturing requires, as you mentioned, as Mr. Gyani also mentioned, large number of facilities, highly cost intensive. I mean, I don't know if you can see some facilities behind me, but almost 400 crores worth of infrastructure is required as common facilities, which is beyond the pocket size of a single manufacturer. Now, this manufacturing is driven by, and therefore, all the scarcity, all the paucity, all the deficiencies that we are talking for 75 years, less doctors, less hospitals, less beds, less nurses, less technicians, more has to come from us. Somebody else from outside will give us. And the big example of this is Ayushman Bharat. thousands of hospitals that are private sector that existed, but beyond the access point of a covered care, beyond the access point of assured or uninsured care, depending upon whether the state follows the insurance model or a trust model. These hospitals always existed in the country, but our citizens were not able to use them without thinking about affordability, and the government was not able to cover them for the process of those hospitals. What has Ayushman Bharat done? It has broken the barrier between the public sector and the private sector. Those hospitals even today exist in private sector. They are managed privately, but they provide for care which is funded by the government. And suddenly, our beds have increased 1 times without adding.
Yeah.
So all I'm saying is the abundance in Bharat, the Nirbharta in Bharat, the efficiency and adequacy is used to exist. To recognize them and make them part of our heritage. Over to you.
I think very good point you made, Dr. Jitendra, is regarding the fact that telemedicine, which is a natural evolution of healthcare in the digital world, was opposed very strongly by the medical community itself. But that has been the fate of all inventions. When the bulb came, Morton, who was a very strong, big scientist and a huge following, he said this bulb is an unpractical device. Because imagine you will have a power station and generating power, then transmitting power to the city, then from the city it will come to your home, and that will light the bulb. And nobody believed that this can happen. But Edison, he invested in Edison Electric and made that entire transmission piece happen. What is called General Electric today was Edison Electric. And then eventually people woke up, and then a whole world was lit up. So what I want to say is that this kind of obstacles have come before also, and many a time it requires somebody like you or like Dr. Rajiv Garg to push it, and many a time it requires a catastrophe for us to wake up, and COVID is proving that. So here I would like to bring in Rajiv. Rajiv, do you agree with what Dr. Jitendra Sharma just said about the self-reliance piece? Rajiv.
Yeah, thanks, Pavanji, and thanks everyone for this opportunity. So, while being an Indian, I believe in Atmanirbharta, and we align to the clarion call made by the Prime Minister in the month of May. So we can approach it in maybe two different ways. One is how we can use or how we can become Atmanirbhar through indigenous capabilities and indigenous way of building capacity, and one is through cooperation. So typically, when we talk about Atmanirbhar Bharat, we generally think about just manufacturing. So coming to MedTech, what I feel is Atmanirbharta in MedTech may not only come just because of manufacturing in India. So what we believe is we should also think about how we can innovate in India so that the local innovation comes into the picture, the investment in R&D is there. And then we also need to think about how we can train in India, how we can build the skills, because medical technology uses is very skill dependent, and how we can create a pool of skilled healthcare workers who can help them optimum utilization of these technologies, and also heal in India, which is I think we have seen some cases in past whereby we have had good amount of medical tourism coming in, but how we can check the outflow of the patient from India and reverse that through medical tourism, which can also help us on foreign exchange. and indirectly build the healthcare infrastructure facility in India as well. And I think, once we are able to do this, the ultimate goal which the Prime Minister has been talking around and the country is also struggling with is how we can spur the economic growth, how we can increase the employment in India, right? So once we are able to do all these four things, then possibly we can reach much faster over there rather than just focusing on Make in India. Because medical technology is per se not very labor intensive industry. Even if there are manufacturing, it may not create a lot of jobs, but through innovation, through training, through healing in India, we can possibly see reaching the objectives much faster.
Interesting point. Sorry, go ahead.
Yeah. So
anything else, Rajiv? Yeah.
1 minute.
Yeah, go ahead.
Another way is also through cooperation. And what I mean by cooperation is like when the Prime Minister also announced this Atmanirbhar Bharat, echoing the sentiments of Atmanirbharta, the Finance Minister also talked about that it should not be considered as isolationism. Means what I'm learning out of this is that looking at the medtech sector in India, which is still around 86% import dependence, the market is around 1.6% of the global size. So while we can go all out, but we have to be very realistic also that how we can approach this and what should be the roadmap. So maybe the message goes out at times is that we are closed for the business. We are going for import substitution. That signaling, we must do that. No, we are open for business here in India, and there has to be some importation as well. Because if you look at any other bigger medical device country who are the biggest exporters, like US and even China and any other, their import dependency is also around 40 to 50%. As per some of the data, in fact, Dr. Jitendar Sharma has also published. So that data also speaks about this. So what I'm saying is all of a sudden and overnight, we can't move from 86% to say 10% or 20%. And there has to be some way forward. And in that, I think we have talked enough around, the policy predictability and how we can, ease of doing business, which we really talked about a lot, but how we can create a single window system and all. So when you talk about policy predictability, we all have seen that, maybe in 2015, when this FDI was open for automatic route, the investment has suddenly increased. But there were some policy interventions, maybe with good intention, but they had some unintended consequences, and that had kept away many investments which has yet to come in India. So those kind of sometimes price control mechanisms, some of the tariff barriers, should be handled in a much nuanced manner, and there are proposals with the government of India. And I think government is moving very fast with the recent launch of PLI scheme and setting up of medical technology park. I think we can reach it much faster. Thank you.
Yeah, great point. You've opened up the debate, Rajiv. What you're saying is basically Atmanirbharta should have a broader definition, not only make in India, but design in India, train in India, and heal in India. And what you're alluding to is instead of de-globalization, you are saying there should be smart globalization, where there is a thin layer of globalization with enough space for localization and local politics, so that the economy can grow without localization shrinking. These are the points which you are making. Let me give the mic back to Dr. Jitendar Sharma for a quick repartee if he wants, before I go to Jaishankar. Or agreement.
Absolutely. Mentioned something very important. Let me tell you that today we are manufacturing a helium-free magnet for MRI in this campus. And that helium-free magnet, this is only the third location in the world to be doing so. Now, this helium-free magnet has components that are not made in India. They have found their home in India because somebody had a component in helium-free MRI. Then this helium lead to an MRI necessarily in India, it may be used by an MRI assembler in France. Medical technology diversity and complexity, right from a titanium used in an implant to a radioisotope, say technetium-99 or something, in a PET CT, to a radiological machine, to a gamma camera, to a robotic cardiac surgery system, pacemaker, ventilator, N95 masks. The diversity from textiles to radioisotope is so high that nothing can be done in one country. Nothing can be done in one country. It has to be a global technological team effort. If we can play a valuable role in this global team effort, we emerge as a medical technology destination, which could be R&D, it could be designing, it could be manufacturing, it could be testing and validation, it could be integration, or any aspect of the value chain. So I completely
Excellent.
agree with esteemed colleague.
Excellent point. What you have pointed towards is a random offshoring between nations may go, but friend shoring will remain. That means we will continue to do business and engage with those countries who are politically similar to us. Their political dispensations are similar. We have a long history of peace and friendship. So they should make the new supply chain from end to end. And what part you play, whether R&D, which contributes 6% of the total global expenditure from India, or it is designing and validation, etc. Whatever is a beautiful point. And let us come to Jaishankar now. Jaishankar, what would you like to add to this piece? You're yourself a big manufacturer of products which are used in the supply chain, plus you're a technological evangelist. What would you like to add to this discussion? You're on mute, please. Unmute, please.
Am I audible? Yeah. So I'll pick up on what some of the points Dr. Girdhar made, Dr. Sharma made, and even Mr. Anish Bafna made. So key points was on accessibility, affordability, and technological solutions. So I'll kind of weave this in as to what the world is looking at in terms of healthcare, and where is India poised, and how does one look at all of these. So if I look at healthcare policies and solutions which are emerging from developed countries, there's a huge shift from focus on illness-focused delivery mechanisms to proactive wellness-focused home care mechanism. No, that shift is very palpable. You have Googles and Apples also contributing towards there. So what does this mean in terms of technology shifts? So huge amount of data storage and collection opportunities, retrieval, analytics. You're talking about disease prevalence. You're talking about huge amount of analytics to understand which age group, which subset, which region has what kind of disease prevalence. So huge amount of analytics is easily available. COVID is presenting that. Eric Topol in Twitter is one good example of how much collation of data of COVID related data you can get at one point. And then there is this whole drive towards integrated devices, interconnected devices, sensor based, very small, affordable, and which can be used in home care. Now I've got plenty of examples to talk about where you have portable ECGs which can be now shifted to village sarpanch houses. You could create clinics in the local medical stores and villages and have preventive tests done over there. Now, then there is talk about care delivery and care enablement right at the doorstep. So this is what the world is moving towards. But I will look at India, and some of the esteemed panelists have rightly pointed out that there is a huge skew towards urban-centric healthcare systems, and there is a lack of accessibility in very remote parts of rural healthcare systems. Dr. Sharma made a point that co-opting private healthcare systems has just somehow eased some of the burden in at least the peri-urban areas to the district level. My sense is there is huge disconnect beyond peri-urban, beyond the district level into the hinterlands of villages. Now, where you still need access. Now, a case in point, let me give you an example. When we did surveillance of the healthcare practices in Assam, we found that very significantly around Brahmaputra, there are around 400 river islands which have never been reached for healthcare systems. Now, some good things have been done by the government. Center for Northeast Studies and Policy Research had started both clinics. They were not able to deliver it because the journey of the boat used to be for 8-9 hours and come back, because you don't have access to storage of drugs so that you can carry more drugs and deliver more efficiently. Now, simple solutions is where we come in. 2 or 3 points just to showcase what kind of impact technology has, whether it is big or small. We brought in something called sure chill technology, which uses a very innovative anomalous behavior of water to store ice as thermal bank. And this allowed the refrigerator to precisely give food for 10 days or 13 days without power. Now, when you retrofitted this on boats, suddenly the boats had capability to carry drugs, carry blood supplies for around a week or 10 days without having whether there will be temperature excursions and there will be wastages of drugs and blood. And they were able to reach around 3 lakh population because of this small intervention on boats. We have a number of cases in Arunachal Pradesh. I have seen blood camps in all these Naxal belts, which have never been access to healthcare. Now we have blood centers now in Chhattisgarh, Jharkhand, and the interior parts of Chandrapur in Maharashtra. So those are some examples. I'd also like to talk about skill sets which are already residing. Now, all it took was this huge pandemic to really bring about the nascent skills which are available. Our aerospace division, which is into missile technology, had never looked at healthcare at that time, was presented with the problem of electromagnetic proportional solenoid valves to be made urgently for DRDO ventilators. So they went about this task, came out with solutions in 10 days time and produced around 3,000 units. So now suddenly this opened a big market, because this is when we compare it with what's available in the world, this is more comparable to what's currently available in the world, passes all the regulatory norms across other countries, and we suddenly see that this could be a huge potential for export as well. So technology solutions are available. We need to kind of have the lens of technology to see whether we can solve age-old problems in a new way. And that's the point I think Dr. Sharma made, and I completely agree with him.
Great point, great points. So you brought in the importance of big data, perhaps it will come up again. The other point which you have made is IoT, sensors. This is very important for a simple problem, big problem which we face is that all over the world, nurses lose about 24% of their time just looking for devices. And this can be sorted out just by having a voice activated sensor on the device, which tells you where it is. And this can reduce cost as well as improve bed turnaround times. The third point which you brought about was home care. Yes, home care and telemedicine combined will not only reduce costs and bring several other advantages, but also many a time it improves accuracy, because you don't get white coat hypertension when you are getting the blood pressure test tested at home. So great points, and you have told how access can be improved. Going back to Dr. Gyani, Dr. Girdhar, regarding the points which have been made, and especially the technology issue which has come, what is your next comment? What is the next big thing which is coming up now?
Okay. Yeah. So, in the first part, I mentioned to you the huge shortage of the beds and huge shortage of the doctors. Now, let me just give one more example. that we have, let us say, 5,000 or 6,000 community health centers in the country, which are actually the backbone for providing the rural health, and these are supposed to have one general surgeon, one general physician, one gynecologist, and one pediatric doctor. And let me tell you, across the India, we have roughly 80% shortage of these people. So virtually these community health center, 5,600, are virtually defunct. Now this shortage we can't meet in next 4, 5, even 10 years. That actually is the fact of life. Although government is taking very fast initiative, they launched a diploma program through DNB, which will convert the MBBS in 2 years' time as intermediate specialist. But still, it will be a long journey, 5 to 10 years. So I think that is where our good friends, including our friend Sharma, have brought out, I have been talking the two segment. I have been telling my hospitals to open up the vertical of the home health. There are home health companies separate, but I am saying even a 100-bed hospital, if they have good on the health with a qualified personnel on their board, they virtually get 500 beds. That means 400 beds they are operating through the home. Issue here is, again the issue is coming here, do we have the home healthcare workers? You really need to speed up identifying skill, reskilling, or rebuilding the skill, because it will succeed if you do people to give the treatment or do measurement of the patient at home. But this is a viable way of doing it. But again, requiring the telemedicine. So that means the doctors are able to consult people at home. It will be wearable, it will require sensors. And I must say, Sharma has started working in Andhra Pradesh. We have been following each other. You see, in this country, we have been launching missiles, we have sent the satellite to Mars. But with simple medical devices, we have not been able to produce. I think this is where awakening came up. I think 5, 6 years back. I think Andhra took the lead role, I will say definitely. And I think if we follow it up a little more intensely, I think our country is capable of, otherwise I think every time we are dependent on MRI, CT machine or X-ray machine, all for import. So if you bridge this gap fast, train our people on the home healthcare workers, I think we will be able to overcome this shortage of doctors to the great extent. But I'm not saying that you don't need doctors. Still, that line also has to go up. I'll give you one more example. You see, we have 11,000 radiologists in this country. I think we have very few people will be knowing here. Only 11,000 radiologists. And unfortunately, our regulation, I don't want to say who has brought this regulation, that only radiologists can do the ultrasound. Can you imagine a pregnant lady needs 4 ultrasound? Okay, at least 2. How can these 11,000 people undertake the ultrasound? And that is why women are dying during delivery. We have worst possible, we have 110 women dying out of 110,000. So I think this is where we have to speed up, improve the regulation, and at the same time, instead of radiologists, we have to authorize down the line other category of people to undertake ultrasound, which is very simple way of doing it. So I think these are the ways. I absolutely agree with my colleagues here that shortage can be met easily by number one, changing bit of the regulatory practices. Number 2, speeding up the telemedicine. And number 3, home health care by training the home health workers. You are mute. Pawan, you are mute.
Home healthcare is 1/10 the cost of hospital healthcare. So it reduces costs. Telemedicine, as you said, it saves time, money, infection risk for the patient, also the risk of bad doctor behavior. And many a time, and there is a term for this, there are millions of people today who have become hokikomori. Hokikomori is a Japanese term which describes people who only interact with technology. They don't interact with people, because interaction with people can cause stress. and interaction with some doctors can also cause a lot of stress. So people are happier not engaging with such doctors. And doctors are also happy not having that waiting room pressure, the missed appointment pressure, and the better follow-ups, the possibility of teleeducation, teleconferencing, procuring, and so on. So telemedicine can really heal patient as well as doctors. Plus, payer, the cost will go down, and there will be arm's length prescribing. Plus, for the government, the shortage of doctors, etc., which you spoke about, will not be such a big problem to handle. So somewhere telemedicine is going to be something like which gives a win-win to everybody. And the only example like this I remember is from Henry Ford's assembly line. When Henry Ford brought his assembly line, the worker wages went up, their number of hours came down, the prices for the customer came down, and profits for the industrialist went up. So it was something which was so good for everybody that it could never be taken off the table. And I feel now telemedicine has something similar. 5 crore teleconsultations have happened between March 1st and May 31st. 5 crore and twice, so 10 crore actually, 8 minutes. This is not going anywhere because doctor behavior can be biased. It can be have linguistic bias and economic bias, etc. But there are some other issues which are there with telemedicine which need to be sorted out. And for that, I come to Dr. Rajiv Garg and also ask him about NDHM because, as you both said in an earlier discussion, that NDHM is the second thing which is coming. Dr. Garg.
So the comment made by Dr. Gyani are really worthy because see there are glaring gaps in the health system. So we have to address these gaps first. And the way forward is the e-health systems like the digital health, national digital plan and telemedicine. There are plans for making mobile wellness centers. Along with the Ayushman Bharat, we'll have the wellness centers which will go to the district level, the village level, and they can be that way you can cover a larger area with just one clinic which is mobile. And you have the example which is our diagnostic labs also were mobile way they were going and doing the PCR test in the peripheries, and the only thing is the telemedicine and all these systems will have to be regulated, and for that the government can't come in. It is the professional bodies of the various specialties who can take care that the patients are protected and the ethical based telemedicine is done. So this way we can almost there can be a quantum leap in the gaps which are there because the numbers are huge, and that way the health systems, the resources can be pooled, and the private the doctors also will have can fill in the gaps. This is what my perception is.
Excellent point. Let me come to Dr. Jitendar Sharma. डॉक्टर साहब, अभी डॉक्टर गिरधार ज्ञानी ने एक पॉइंट बोला that the regulation is extremely limiting and constraining. The boundaries should be relaxed. The ability to practice cross-discipline activities should be allowed, especially where basic level of expertise is obtained already in the first discipline. So, but when governments are asked it is said that governments are not so thorough in drafting of legislation or regulation or resource allocation. So how can we ensure that there is greater thoroughness and foresight in the regulations? This is one point. Of course, I know that you represent another breed of regulators and government officers, which is why I'm asking you this question. And that's my first question. And second question is, how can we make the reception of capital which comes, people like Anish Bafna or people who have enough capital, they come, they get a reception which is really welcoming. How can we have some bureaucrats, or if bureaucrats have to do that, who will be very cordial with them and who will be immune to the pressure which will come from the bureaucracy on them to behave a little feudally with them, so that they do not, so that some kind of hierarchy is maintained. And I'm asking this question as as representing one of the largest groups who brings investment. You just noted that Medtronic brought in 1,200 crores. So you are from a different breed of bureaucrats. That is why I'm asking you these two questions. How can we make regulations more thorough and reception more welcoming with a bhav of samrasta and samadar for the businessman? Not sir.
Thank you very much. You started your question by saying Dr. Girdhar Gyani mentioned. Let me tell you that if Dr. Girdhar Gyani has mentioned something on quality and standardization, it does not need any further validation, because that comes with decades of service to a healthcare quality paradigm in India. Because his insights don't come from PowerPoint presentations. They come from the real problems, challenges that hospitals face. And I'm only going to supplement him. I will tell you an interesting example, and it's very peculiar comparison. You see, I hope you pay income tax, right?
Lots.
And when you pay income tax, you obviously declare your income. That's why you pay, right? What if I don't ask you what your income is, but start blaming you for paying less tax or more tax? Will I be fair? I will not be. I can blame you for paying less tax or more tax, but if I prohibit myself from knowing your income, I have no right to tell whether your fall in tax or increase in tax was due to your income or not. And yet we have a beautiful PCPNDT Act which says don't detect the fetus, but if the gender ratio falls, you are to be blamed as a doctor. अरे भाई, जब आपने जेंडर डिटेक्ट ही नहीं किया तो आपको कैसे पता चलेगा कि जो फीटिसाइड हुआ या जेंडर डिक्लाइन हुआ that was because of the gender? The ideal thing would be like income tax, mandatorily declare the gender and follow every girl child. Because if that girl child whom you have already identified and tracked dies or is aborted, you can penalize the person as you penalize the person who declares the income and pays less tax. No, it's just a once we do that. What Girdhar Gyani mentioned is 1100 ultrasonologists, 11,000 radiologists, and also gynecologists who have done the ultrasonography course in some cases. We have restricted that number because of that law. And when you course correct that law, this self-imposed restriction goes away. Because irrespective of who uses an ultrasonography machine, you have to mandatorily declare the gender. And then you have to follow it. And they have to ensure that if it is aborted, the penal corrections are done. That would be an evidence-based policy approach which needs to come from an open mind. Now, do administrators have an open mind? The answer would always be mixed. It would depend highly on the person. The second question that I wanted to answer is that ISO standard, IEC, the International Electrotechnical Commission standard, which is compatible with ISO, adopted by 6 regulators, including European Union and FDA, IEC 60602-12, standards for ventilator, requires a volume accuracy of 10%. Now, this 10% volume accuracy is tested by using a fluke gas flow analyzer, and the fluke manual declares that the analytical instrument's accuracy itself is 4%. which means if you are making a ventilator, the accuracy acceptable as per international standard is 10%, and the instrument you use to check this itself has a least count of 4%. Yet, in our specification for ventilators, we ask for volume accuracy of 2%. Now, asking 2% is not wrong. What is wrong is that if you have to give a 2% volume accuracy, you need a sensor that can measure it, the cost of which is 25 times than the cost of the sensor which can give a 10% volume accuracy. And therefore, when we differ as a country from the international benchmarks and standards, we are crucifying value chain. We are making production unviable for nothing. Right? Now, no page is a blank page. Every country, including India, starts with some things written on it, some things designed by our forefathers, some things designed by the planners of healthcare system before we came on the bench. All we can do is to, without criticizing the history, write a script as best as we can. And in writing the script, I can only see three things that can change the game. Number one, what Dr. Girdhar Gyani mentioned, but he mentioned an example, which is home health care. I am saying not home health care alone, not blood services alone, not essential diagnostics alone, not pathology alone. Uberize healthcare. Use the Uber model where a provider, instead of using a 108 ambulance, a patient using a 10 ambulance can download an order for an ambulance, even if that ambulance is a private sector, and the driver gets 12 rupees per kilometer fare paid from the National Health Mission, instead of National Health Mission buying ambulances after ambulances and fighting with drivers' associations.
Yeah.
So when you Uberize healthcare, you disrupt resource pooling because you are ready to pay for every single entity. Use health technology assessment so that the worth of innovations can be brought in. All knee implants, all pacemakers, all valves cannot be the same. They cannot be the same. They may fulfill certain basic tenets of safety and efficacy, but beyond those baseline benchmarks of safety and efficacy, each innovation, each product has a value to it which is distinct. And you can recognize this uniqueness only when you use health technology assessment and measure their impact vis-a-vis their costs. Number three, the course correction which are of regulatory nature. For example, PCPNDT Act that we discussed. For example, the Drugs and Cosmetics Act medical devices rules, which today has a notification that regulates a PET CT scan in India, but not a mammography. It regulates a defibrillator, which has an inbuilt ECG sine wave measurement tool, but not an ECG machine. A regulatory course correction. And we don't need a single regulator. We need a single regulatory platform. Because medical devices needs regulation right from NIV Pune and ICMR to, if I were to manufacture insecticide treated bed nets for malaria, I need the toxicology board approval, which is another ministry. I need approvals of National Institute of Biologicals Pune for my panels and zero conversion panels. I need AERB license for my radiation products. So medical devices needs a common virtual regulatory platform where every regulator can log in, fulfill his or her mandate, but for the manufacturer, it is a seamless journey. So if we can put this triangle together, which is Uberizing the market of healthcare, bringing health technology assessment to reward innovations for their incremental advantage, and do very disruptive course correction through evidence-based policy making in our regulation, I think we will leapfrog into a much better world of medical technology and healthcare in India. Over to you.
Dr. Sharma, when you started, मैंने सोचा आप मेरे प्रश्न को ही गहरा कर रहे हो, मेरे प्रश्न में ही अपनी आवाज मिला रहे हो, लेकिन जब तक आपने खत्म किया आपने बहुत सारे अच्छे पॉइंट्स बोले। पहला पॉइंट तो आपने ये बोला कि सब रेगुलेटर्स एक जैसे नहीं है, सो रेगुलेटर्स या ब्यूरोक्रेट्स की भी और ट्रेनिंग एंड और ओपनिंग ऑफ द माइंड्स होनी चाहिए, जिससे सबका उस तरह का दृष्टिकोण बने जैसा कि मैंने रिक्वेस्ट किया था। और सेकेंडली आपने ये बोला हार्मोनाइजेशन लाओ, टेक्नोलॉजी लाओ, हेल्थ टेक्नोलॉजी असेसमेंट लाओ, और रेगुलेटरी कोर्स करेक्शन के लिए भी टेक्नोलॉजी का इस्तेमाल करो, मे बी ब्लॉकचेन का इस्तेमाल करो, बाई ब्लैक प्लेटफॉर्म ले आओ where everybody adds to that indelible ledger of blockchain, where the signature of that person is present and it is verified by other people also simultaneously, so that the regulation does not infringe into impractical areas. Great points. Coming to Anish. Anish, you have worked in so many countries, including Singapore and Japan, particularly Singapore. And I would like to know from you, what have you found in the regulation and receptivity for enterprise and capital in those countries which you find missing here? And in a very constructive manner, let us add to the excellent points which have come from Dr. Sharma and also Dr. Gyani and Dr. Rajiv.
Yeah.
Go ahead, Anish.
Thanks, Pawan. I think, Dr. Sharma was very articulate in expressing what are also the needs of the industry. And I think two points that he sort of articulated. One was the earlier one, which was that, investments are driven by market. And if there is no market, then it becomes very difficult to attract investments. And the second point, if I were to sum up, what he said in the recent answer, was that there has to be ease of doing business so that companies can focus on getting the right product to the market, making sure the right qualities of the product are maintained, right? I guess these become very, very important. And this is where I guess, one element is, the domestic market itself, right? The domestic market has footprint in India, has to grow for it to become interesting for people to invest out here. And we have the population, we have the need. The only question is that, and I think a lot of it will be answered by Ayushman Bharat and the advent of insurance in the country, which will allow more patients, more access, and drive affordability. But I think the size of the domestic market really has to grow. And it cannot be a local versus foreign company layout here, because we really need to make the market attractive for the multinationals to come and invest out here in this country and set up their manufacturing footprint out here. And facilities like the AMTZ are already in place for them to come and put their footprints out here. But their decisions are going to be driven by economics, which is what a lot of these markets like Singapore, like Malaysia, like Thailand do, where they make it attractive for a company to come and invest. The second is, these companies will automatically give a rise to a lot of ancillary units that will not only supply to them, but will also make India an export base. The second point is, how do you make local companies prosper? Because while we want a lot of multinationals to bring in a lot more manufacturing into the country, you also need a very large number of local players. Now, with what has happened in the last 4 or 5 months, I think the opportunity for the Indian manufacturers to take over a lot of the Chinese supplies has become extremely attractive, right? And for that, what we need to do is make sure that a few parameters around quality are critical and critically managed. One is that there has to be a far more stringent view while granting approvals and licenses to manufacturing units. There is no reason why an Indian patient should get a product which is second class. Yes, he should get it at the right value, but he should get a product that is comparable to the best anywhere else. And for that, local manufacturing has to be regulated. The second point which Dr. Sharma very articulately put down was the harmonization of quality standards, right? Make it easy, make it harmonized so that I can manufacture in India and also make India an export base for my international forays. Now, India is a value-driven market. The pricing of the product is definitely going to be lower than a lot of other countries, but that can be made up by two things. One is economies of scale. The other is making it easy for whosoever is putting manufacturing in India, whether a multinational or an Indian company, to use this as an export base and create a large export out of India, right? And I guess that's where the reinstation of the MEIS scheme becomes very important, because you will make larger dollar revenues by selling the product outside India. Utilize those funds to sell, focus on R&D and technology in India. And I guess the other point I'd like to make is around the MSME sector, right? We really need to have a very vibrant MSME sector. Today 809 companies contribute to only 5,000 crore of sales in the company, and we need a very large number of both ancillary units, MSME segments, that will give us a platform of very large products that can cater to the local market as well as the international market. So I guess this is where we really need to put our minds together as to how do you make the market size larger and the industry more focused on both the domestic and the export markets.
Excellent point, and every point was made so articulately. I would like to catch one point which I like most among all the good points you made. That is regarding that no patient is willing to accept a second-class product. E.F. Schumacher, a very noted economist who wrote the book Buddhist Economics, which asks for the middle way and recommends adequate, appropriate technologies, not top-class technologies, appropriate technologies for poor nations. He found out later that his appropriate technologies for poor nations is not working, because poor nations are saying that this is a euphemism for poor technology for poor nations. It is a better way of calling a poor technology for a poor nation. You call it appropriate technology. There were no takers. And in healthcare also, there are no takers. So what you're saying is we have to use our ingenuity as well as technology to make quality affordable. Great point. And to close the discussion, I would like 1 minute each of you on this last point, and I will start with Rajiv. Rajiv, there is a debate which is happening that whether healthcare should make profits or not, whether hospitals particularly should make profits or not. What is your view on this? 1 minute from each of you. I'll start with you, then go to Jaishankar, and then come back to the other panelists. Rajiv.
Yeah, Pavanji, it's widely known that you can't feed from an empty vessel, right? And in recent past, in many conversations, we have seen the word profiteering being leveled to private sector, whether it is MedTech companies or it is the private care providers. So I think unless you make a profit, it is very unviable. So profit versus sustainable profit, these are the debates we can have, right? But you can't say profiteering. And looking at the healthcare providers, if you look at the EBITDA of top 10 hospital chain in the India, I'm sure they are not in even the double digit. So they also have the challenge. So somewhere we need to change that perception and also try to strike a balance, because we also say that हम बिल के बोझ से ना मर जाएं, बीमारी से तो बचे, बिल के बोझ से नहीं मरना चाहिए. तो I think that is something where we need to strike a balance, but definitely we have to prosper together.
Yeah, what I said was कि दिल के दौरे से अगर हमने पेशेंट को बचा लिया, लेकिन वो बिल के दौरे से मर गया, तो क्या बचाया?
Correct.
Great point. So coming to Jaishankar, what is your view on this?
I think to some extent what Rajiv articulated is true. No, profit in a way fuels the next journey of technology innovation. Somewhere the money has to be plowed back to the business to progress further in the journey towards a larger and more viable healthcare system. And profit is one thing which fuels this. And when we talk about laborers earning more, more consumption, well-being, and upliftment of quality of life, all of this has to be fueled by someone earning and paying for it. and no, everyone can't be at become an NGO service. So the whole nation is built on a capitalistic model. Yes, sustainable, reasonable profit is something which we all look forward to, which will fuel the growth of further advent of more technologies, more infusion of better quality of life.
Excellent point you have made. Technology makes things which are today very expensive, very inexpensive tomorrow. And for making sure that things will become affordable, you should make the innovator make some money so that the incentive to innovate and lead to affordability doesn't go. Great point. Dr. Gyani, आप बताइए डॉक्टर साहब, आप इतने सारे हॉस्पिटल्स के मुखिया हैं, आपका क्या प्रेफरेंस है? और उसके बाद मैं डॉक्टर गर्ग के पास आ रहा हूँ।
अच्छा, ठीक है। देखिए, मैं चलिए एक एग्जांपल देता हूँ। हमारे एडवोकेट हैं आजकल, हम उनको एंगेज करते हैं, वो 40 लाख रुपए लेते हैं एक हियरिंग के। डू एनीवन रेज आईब्रो कि यार 40 लाख 5 मिनट की हियरिंग के लिए हमने वकील को पे कर दिए? एक डॉक्टर को 1500 रुपए वो चार्ज करता है कंसल्टिंग के। ह्यूमन क्राइम मचा हुआ है पूरे देश में कि डॉक्टर्स आर प्रॉफिटियरिंग। अच्छा, दूसरी बात आप ये समझिए कि आइडियली ये होता कि हमारा इंडिपेंडेंस के टाइम प्राइवेट के पास थी, 92% गवर्नमेंट के पास थी। अगर गवर्नमेंट को पूरा हेल्थ केयर अपने पास रखना है, दे कैन डू इट। पूरा इन्वेस्ट करें और पूरे हेल्थ केयर को नेशनलाइज कर दें और अपने आप चलाएं। लेकिन आई टेल यू, बीइंग वर्कड इन गवर्नमेंट फॉर 30 years and now representing private sector, it will not be a viable, not a good move. Government अगर इंटेलिजेंट है, which they are, they should rather provide more space to the private sector, but as I said, regulate them intelligently. Intelligently is the important word here. अब सवाल ये आ रहा है कि what is the cost of delivery of the healthcare for particular procedure? मैं आपको बता सकता हूँ, none of us know in this country what is the cost of delivering a cesarean section, CABG or any procedure. तो हम लोग क्या है, वो एक्चुअली इसमें कंफ्यूजन ये है कि गरीब आदमी जब गवर्नमेंट के पास जा रहा है तो फ्री हो गया, प्राइवेट के पास आ रहा है तो 10,000 रुपए देने हैं या 15,000 देने हैं, 25,000 देने हैं। एक्चुअली इसलिए वो कहता है कि बहुत महंगा है, बिकॉज वी डू नॉट नो कि जो गवर्नमेंट में उसे इलाज कराया है कि कितनी कॉस्ट आई, नोबडी नोज इट। इवन द डॉक्टर्स हु आर दी, इंक्लूडिंग हमसे एम्स का डॉक्टर, उसको आप पूछ लीजिए कि हमारे प्रोसीजर की कितना खर्चा आता है, इवन ही विल नॉट नो। सो आई थिंक देयर इज now that which government is doing it through Ayushman Bharat and through other schemes, they are trying to deliver the healthcare through the private sector and paying them. Good model. Only thing is यहाँ पे जो conflict आ रहा है कि पेमेंट कितना होना चाहिए, वो कम है, ज्यादा है, टाइम से नहीं मिल रहा है, CGHS, ECHS में बड़ा बुरा हाल है पेमेंट। वो थोड़ा सा अगर हम ठीक कर दें तो आई थिंक अल्टीमेटली द ओनस इज ऑन द गवर्नमेंट कि हेल्थ केयर, एजुकेशन एंड एनवायरमेंट तीनों चीजें गवर्नमेंट की रिस्पॉन्सिबिलिटी है। अब इसको गवर्नमेंट को पूरा करना है आई themselves or through the private sector, and they do it at the right cost, and at the same time, last point, hospitals also have to improve. They also have to cut down the, improving the efficiency, I am saying, not nothing else. There is a huge margin of improving efficiency. आज एक पेशेंट जाता है, उसको पहले एक रेडियोलॉजिस्ट देखता है, उसके बाद गायनेकोलॉजिस्ट देखता है, फिर उसके बाद उसको हम कहीं और भेज देते हैं। हमें इंटीग्रेटेड वे में एक टीम बनानी है जो कंडीशन को ट्रीट करे रादर देन एनी पर्टिकुलर एलिमेंट। तो वहां भी स्कोप है। तो ये सारी चीजें हमें करनी पड़ेंगी, then only I think we'll be able to do it. But Indians, let me tell you, all of us sitting here, including are very intelligent people. जिस दिन ये मन बना लेंगे कि हम करना है, we can overcome it.
Excellent point. And I will make a short comment on that later. Coming to Dr. Rajiv Garg. Dr. Garg, what is your view on this?
See, I fully agree that if you have to introduce advanced and modern technologies, whether it is therapeutic or diagnostic, you need money. It is an industry. And after all, if the industrial, enterprise does not make profit, what is the whole point? So there is a need for, rationalization. That's the only thing. for example, this in the COVID era, the RT-PCR, the government, did not interfere when the court said they can be charged. And it was, initially somebody made a noise that every private lab should do it for free, and it is not practical. So it was fixed for a particular amount, and it is still there. And although the kits may have become cheaper now, but still the key thing is that it has to be, there has to be a model. Like, for example, in Delhi, there are several hospitals give the free beds to the, PPL patients. So that, I think, is a sustainable model. And I agree fully that the money has to be there. That's it. Over to you.
Great point, Dr. Saab. The top leadership, the Prime Minister of the country, is aware of these arguments, and we have had the pleasure of witnessing face to face and in person the width of his knowledge and the depth of his understanding. However, some part of the political elite may feel that India was the first country which came with hospitals. These hospitals were made in the city by businessmen, and it was a charitable enterprise completely, free. So they may expect that today also it should be done charitably only, the business of healthcare. What they fail to realize, that time healthcare was not a standalone business. Merchants of other trades were pooling in their excess profits and running those healthcare units charitably. Today, healthcare has become for many people a business. So, how will he make sure that he can do good without doing well? How will, as Rajiv said, he will feed from an empty vessel? And Dr. Gyani, he made a beautiful point. And this point was made to me by Dr. Risam also, ex-MCI member, who I'm sure Dr. Gyani must be having as a friend, as I did. He said that I and my classmate, we compare with each other. He's a lawyer and I'm a doctor. And he gave me a similar example. That time, the lawyer fees was about 30 lakhs, not 40 lakhs. So that's the only difference. So he says, why should I not have the same privileges for my kids as he can provide for his kids? And same point is being asked by the investor today. Investor is saying that if I have to participate in healthcare, and I advise a couple of P funds. So they are saying, if I have to participate in healthcare, and it is this price control thing is going to come anytime. So my profit is as it is, you're saying it will be less than 10% and it may go to 2% or 5%. Then why should I not put my money elsewhere and gain a better profit? So what is your view on this, Anish? What's your view on the profit as a justified profit as a good goal for healthcare companies also, Anish?
So, Pawan, healthcare is a very different subject, primarily because, you have to cater to a very large population that is not able to afford it, and make sure that, the same quality of treatment, the same quality of product is available to them. And then you have a segment that sort of has the ability to give it, right? So it's a very big balancing act, and it cannot be one versus the other. But I would sort of deviate slightly from the healthcare paradigm and make a statement that if you have to finish first, you have to first finish, right? And if we look at the 1970s, two statements were made in two different countries. In one country, the statement was, to be rich is glorious. In the other country, the statement was, Garibi Hatao. Right? It is, I rest my case on which country has been able to reduce poverty primarily by making sure that they are able to, create large sources of wealth for that country, right? And how the other country has been able to manage it. Again, I'm not mixing it with healthcare, but it's very important that economics plays an important role. I mean, if you look at the last quarter results of the large hospitals, they have lost out significantly, right? I mean, if they do not get into the profit pool. And the profit can of course be regulated, and you cannot charge whatever you want on the earth to a patient or to a customer. But at the same time, if they don't make money, where are the extra beds going to come from? Where is the development on R&D and technology going to come from? So it's a vicious cycle. And the question is that, if economics is kept at bay, the rest of the cycle will not come into play.
Great. So you're saying that if you will invoke Seva Bhav, very soon the investor, though he will nod in front of you about that noble goal, but very soon he will exit the room. Dr. Sharma, your last points, last words.
Again, I would say from my examples of real work, we are shortly touching 5 lakh RT-PCR kits per day production capacity in my zone. 5 lakh kits a day, right? And that's almost 60% of India's testing numbers at this moment. And that's per day. When we started production of RT-PCR kit, I was pricing it at 1199 rupees. Now it is somewhere around 500 rupees per kit, per test kit. Profit improves manufacturing capabilities. It reduces the cost. So profit is extremely non-negotiable. On the 3rd of December 2012, when I came back to India from the WHO headquarters in Geneva and set up the first medical technology department in the Ministry of Health at Munirka campus, which became in 2 years India's first and world's 4th WHO collaborating center on medical devices, and first within Ministry of Health ever to be made. As a Ministry of Health's advisor and director of that center, in 2012 to 2016, when I was there as part of the Nirman Bhavan team, I never cared about profit because I was not giving them salary. All my consultants, all my experts were being paid by the Ministry of Health. I had 125 people in that campus. Today, I have 3,000 people in my campus. Unless I earn profit, I cannot pay their salary. Ministry of Health is not going to pay. Ministry of Commerce is not going to pay. They shouldn't be paying, because the people who work here, they are supposed to make, deliver the products to the country to earn their salary. And that salary comes out of profit. All I'm trying to say is profit see, हमें तो ऐसा है कि in healthcare, you are anyway converting your karma into dharma. You are anyway working for saving life at some point of healthcare value chain. So seva to non-compromisable end point hai hi. You can't get away from it. With that seva bhav, if sustainability is added, that profit, that sustainability would lead to improvement in manufacturing and service capability. That manufacturing and service capability would lead to reduction in cost. It's a positive cycle. And therefore, I think as much as we give 5-star rating to energy efficient organizations, as much as we give 5-star rating to organizations that do CSR, I think we should also give a star rating, a championing award to those companies in MedTech and those hospitals that make a very reasonable and commendable EBITDA. Why do we exclude EBITDA ratings from awards? Because the more sustainably they earn, the more they would add to the manufacturing and service value chain, the more they are only going to help reduce the cost, because it's a positive cycle. Thank you very much.
Points which have come up in this discussion, the last piece, are contributing to each other, and we need to balance them. So when you say, you made a very good point that RT-PCR kits came at 1100 rupees, not only 500, Today at 400 rupees also the same kit is available, which means there is some introspection you are asking that the industry should do. That if you can still supply the same kit at 400 rupees, assuming profitably, then what profit were you earning when you launched it at 1100 rupees? And what was your case for it? Were you not having that much volume, etc.? Great point. And on the other side, what Anish has said, that there were two countries. One said, go for economic incentive, go for uplift of standards of living for everybody, achieve, acquire. And the other said, Garibi Hatao. The country which said Garibi Hatao sounded much more noble, but did not prove that noble goal never materialized. Garibi only spread. So the point which I think is in the balance is an inspiration which we can take from Margaret Thatcher. Margaret Thatcher was a chemist by training and also a lawyer. Her cases were very watertight, very thoroughly worked, and so much so that people used to call her forensic, and she used to love this moniker forensic. So that thoroughness of policy is required, which makes sure that there is a balance, very good balance between the economic incentive and the desire to do well and share with the community. Healthcare should stay a sector where we can do good as well as do well, and we will be able to do good only because we continually do well. So great points, great panel. Thank you very much for your insights on the market, on the technological and manufacturing ecosystem, regulatory piece, telemedicine, and finally, the balance between doing good and doing well. Thank you very much. Amazing panel, and thank you very much, audience.
Thank you, everybody. Thanks.
Thank you. Thank you.
Thanks, everyone.